Hi all, this is Eric Christensen, founder of MedEd101.com. I appreciate you subscribing to the site. Please feel free to reach out to me, email me if you're struggling with any medication-related concerns, questions. I certainly take those into account. Who am I? I'm a clinical pharmacist, board certified in geriatrics and pharmacotherapy. I work at nursing homes, assisted livings. I work with patients out in the community, and basically I help physicians, help nurses, other healthcare professionals with medication-related questions. So you might be asking yourself, why MedEd101.com? I've run into a lot of different medication-related problems, and I want to try to prevent them from happening. So whether you're a student, whether you're a practicing clinician, I think I provide information that can potentially help all of you become better at what you do and help prevent medication-related problems. There's a little bit of what I'm keeping busy with when I'm not working. So those are my two kids. They are 4 and 1, and yeah, they absolutely keep me running. That's for sure. All right, let's get into the 10 Commandments, what you guys are all here for. So, thou shalt not start, ask for, dispense, or administer a medication without reviewing a medication list. And most importantly, we need to make sure that list is actually accurate. One of the most common things I see is med reconciliation issues, patients not taking medications the way they're supposed to. I've got some case examples here. Example of a duplicate therapy because it wasn't identified what medication the patient was on. So we've got a scheduled NSAID, diclofenac, that's prescription, and then patient didn't realize, wasn't educated, didn't remember that over-the-counter ibuprofen works the exact same way, so potentially putting themselves at high risk for GI bleed, edema, and different side effects like that are common of NSAIDs. Second question there, are they taking their medications? So often patients forget, they experience side effects, they simply quit taking their medications. We need to assess this at every interaction, every visit, to really identify what exactly is doing what. Obviously they can't be having side effects from a medication if they're not taking it. So we need to rule that out right from the start. Herbal medications, St. John wort is a classic example that interacts with a bunch of prescription medications. We need to remember herbal medications as well. And along with that, what indication are we using that herbal medication to treat? That's often something that isn't thought about, but is something else undertreated that the patient is trying to basically self-treat themselves. And most importantly there, we need to have this information to make the best clinical decision. One piece of information missing, absent, wrong, incorrect, whatever, can really change the way you look at a case and the way you would change things as far as their medications go. We need to consider not using medications first. So if there is a condition, disease state, that we can do things about without using medications, do it. So in the instance of, mild to moderate pain, maybe ice and heat work really well for an acute pain situation. Why not try that first? Obviously we've got to assess and see where how severe the pain is and such, but, why not at least think about it or have it in the back of our mind thinking about that. Dementia-related behavioral issues. This is a huge problem. It really is a problem. And if you've worked with patients with dementia, it can be extremely challenging to understand what's going on and to try to help these patients. I've got lots of great examples of kind of outside-the-box creative thinking that I've come across in working with patients with dementia. At one nursing home facility, I remember they had a family create a video of basically what just talking about their day, and had kind of each member of the family saying what they did. And whenever this resident would get physically aggressive, angry, yelling, swearing, delusional, they were able to redirect this resident to that video, which gave them comfort. It helped relax them, and it really worked most of the time for that patient, rather than using an antipsychotic or other, an anti-anxiety med like Ativan or benzodiazepine. Here we were able to intervene with a non-drug approach, not having any side effects or anything like that, and make this patient's life better without worrying about those side effects, interactions, and so on. Lifestyle changes. Obviously, we all know, we all understand, exercise, eating well, those things can help multiple disease states. I won't go into that too much more. So, reviewing if a medication is effective. That is one very common thing that gets missed. Whenever we have to add a new medication for a disease state that is currently being treated, think about that. Why are we having to add another medication? That should lead you back to the question of whether those previous medications are actually doing anything. So in the case of a pain situation, maybe we add Tylenol. Well, then we add an NSAID, and then we add an opioid. Really reassessing to make sure that they at least got some benefit out of that medication if we're adding others to it. So again, think about why we need to add a medication. And there are certainly times, pain, blood pressure, where we basically use different medications from different classes together. So there certainly are those examples where that might work well together. But if you recognize, if you're following closely, you should be able to tell if those medications are working, and then cut out the ones that aren't. It also kind of ties into not starting multiple medications at once. So if you dementias, I'll go back to kind of that dementia-related behavioral case on the previous page. What happens a lot is people really struggle with treating behaviors. So they might rule out pain, they might rule out this, they might rule out that. Well, many times I see these medications, multiple medications started at once. Well, that really puts you in a tight spot as far as what medication was effective for that patient. It's really virtually impossible to identify, if we add multiple medications at once, which one was doing what. So really, if we can at all help it, add one medication at a time so we can help that assessment piece to see whether that medication is effective or not. Considering any new symptom is an adverse effect of another medication. This is probably the one most important principle you should think about when you're working with geriatrics, with polypharmacy. The prescribing cascade, it really does happen. It is common, and it's just a matter of fact of paying attention. So, like an example would be, you add, let's say, Aleve for pain. Well, that Aleve happened to worsen that patient's CHF, so you might see a Lasix increase, or Lasix started. Well, with the Lasix addition, all of a sudden that patient has frequent urination. Well, then we end up adding ditropan, or an anticholinergic, which can cause confusion, falls. Well, maybe they get diagnosed with dementia, and then we get, an acetylcholinesterase inhibitor like Aricept added. It's basically that chain of events where if we would have found a better medication than that Aleve in the first place, or identified those side effects right away, we could have changed that Aleve to something that wouldn't create that cascade. So paying attention when medications are added is really important, and identification of side effects quickly or right away is very important. So know this commandment for sure. We need to have an indication, and we need to assess lab work. It's common to see symptoms of an underlying undertreated medical condition that may tie into other medications being added. So for instance, hypothyroidism might present as symptoms of depression. They may mimic each other there. So what happens is they get those symptoms are identified, they get diagnosed with depression, then we add antidepressants, and 3, 6 months, 12 months later, hopefully we identify that they were hypothyroid, and we can replace that. But a lot of times what gets missed is that antidepressant that was added previously, when maybe their symptoms were simply from hypothyroidism, not from an actual diagnosis of depression. So really, assessing lab work can help you prevent polypharmacy. Drug levels can also be beneficial in the event of suspected toxicity. Digoxin can cause a lot of GI symptoms, can lower pulses when we're experiencing toxicity. So it's important to assess those medications that we can with drug levels to make sure they aren't toxic. Kind of the classic case I've seen is with digoxin toxicity is those GI symptoms where Zofran will get added or PPI, and the patient will continue to have ongoing, nagging loose stools, GI upset, their stomach hurting, and, digoxin toxicity was not ruled out. So those levels can really help us identify potential side effects. Identifying limits. Occasionally I'll see, I had a case a little while back where they were treating incontinence, so they added an anticholinergic, I think it was Vesicare, and the patient also was diagnosed with a UTI at that same time. Well, those two medications were added the same day for the symptoms of the UTI. Well, what ended up happening, of course, was the antibiotic was for 7 days, ended up getting it, treating the infection. Well, they never needed an incontinence medication previously to the UTI, so why would they need one long term? Prednisone and diabetes management. If we get large doses of prednisone, can really raise blood sugar significantly. But when we come off of that prednisone, okay, now we need to be thinking, okay, did we increase that insulin? Did we change their diabetes meds? Now are they going to be at risk of blood sugars too low? So always important to think about when we're discontinuing medications, that is a change as well as starting medications. Acute versus chronic pain management using scheduled analgesics. So maybe they have a hip fracture. Hopefully that pain is self-limited or fairly short-term. In the event that analgesia is scheduled to control that pain, which it very well might be sure we reassess that, week, 2 weeks, couple months later, to make sure that chronic analgesia medication is still necessary. So setting up points along the line to assess these medications is really important as well. Duplicate therapy. Do not use two medications from the same class. There are very rare exceptions to this, but if you ever see this, you better be questioning yourself, why are we doing this? We better have a very good reason. I've seen duplicate meds for dementia, I've seen SSRIs, I've seen analgesics, I've seen hypertension meds. Most often it is a mistake or an oversight where they have a list of 10, 15, 20 plus meds, and either the provider, the pharmacist, who's ever working with that patient absolutely just missed it, that they were already on a medication from that class. So really important to double, triple check if you see medications that that work via the same mechanism of action. To ask the provider, ask who's ever in charge of that patient's medication management to assess those medications. Thou shalt not initiate a medication without considering meds that may treat two conditions. So, killing two birds with one stone. Sedating antidepressants. If they struggle with insomnia, if they have depression, let's use an antidepressant that maybe is more sedating. So an example there might be Remeron. Another situation where Remeron might be beneficial is in weight loss, in dementia, with depression coexisting. Now, you can't always use that. People have allergies, adverse reactions, so we need to assess the whole picture. But utilizing some of those medications that can potentially do multiple things can help us minimize that medication load. Pain and mental health disorders. So maybe rather than using generic Zoloft and Lyrica or gabapentin, maybe we could use duloxetine or an SNRI to help treat, a neuropathy and a depression. Hypertension and BPH, using a non-selective alpha blocker may be of benefit. Those maybe aren't the greatest medications in the elderly to use, but it's certainly something we need to be thinking about. One other case I just ran across the other day was somebody with chronic diarrhea. We had assessed everything, ruled out virtually every medication they were on, and the provider wanted to start Questran for those loose stools. And it worked. Well, they were also on Zocor and a low dose of Zetia for their cholesterol. Well, their cholesterol levels were fine and actually lower because Questran actually is used in the treatment of hyperlipidemia. So what we were able to do was discontinue the Zetia and maintain cholesterol levels just fine. So kind of thinking outside the box, thinking about some of those issues can help you minimize polypharmacy. You really need to have a mindset of eliminating, reducing medications at every visit, every interaction. Think about the medications they're on. Are they solving a problem? Are they solving a problem that was short term? And the really challenging part to minimizing polypharmacy is that patients generally tend to come in seeking a solution. Well, it's easy to see medications as a solution, and they absolutely are in cases. But if that's all we do is present a medication at every visit, interaction, to solve a potential problem, you're going to end up with lists of 10, 20, 30 plus medications, which I certainly see almost on a daily basis. So keep in mind that discontinuing medications may be a solution. That example I presented with the prescribing cascade. Discontinuing that Aleve could have potentially prevented all those other problems from happening. So it's really important to keep that mindset. Okay, what medications did we start? What medications aren't working? What medications are working? If you don't think about discontinuing medications or reducing that medication load, you're probably not going to do it because it's easy to not rock the boat. I want to talk a little bit about risk. I certainly realize there is risk in discontinuing medications, and you should too. People fail off trial reductions, they fail off discontinuing medications. It absolutely does happen. But what isn't really widely recognized is that there is risk to continuing medications. Every medication has potential side effects. Every medication has potential, or virtually every medication has potential for drug interactions. So when we get to this point where we're adding, it starts to basically starts to add up and cause more and more problems. The other thing, I think about, and especially where it might catch up to somebody, polypharmacy might catch up to somebody, is in the elderly, where maybe renal function starts declining, kidney function starts declining. You end up with drugs that can start accumulating. So those drug levels in the body can slowly rise over time, and you end up with potential toxicity. So just because we're not doing anything, not changing anything, doesn't mean we're automatically okay or safe. There is absolutely risk to continuing medications long-term and indefinitely. There's also a few medications with long-term side effects. So really important to understand there is risk in discontinuing medications, but there is absolutely risk in continuing medications as well. And there they are, guys. Thanks for your time. You can check me out at meded101.com. If you're interested in guest posting, you can certainly reach out to me, drop me an email. If you're interested in a certain topic, question, whatever, feel free to drop me an email as well. Thanks, guys. Appreciate your time.